That's great. Thank you very much, and thank you very much for inviting me here today. So Arvind and Maureen have articulated very clearly what we all know, that we've got no capacity, and if we don't find ways to reduce demand, general practice is going to struggle to survive. As Arvind's outlined, the general practice forward view does give us an opportunity to make the changes to help us survive, and it is a good place to be starting. But at the same time, as our problems with capacity, we also know that if we don't get better at prevention, the NHS will not be sustainable. But this can make us a bit anxious in general practice because we know we've got no capacity to be doing more about prevention, for example. And anyway, most of us understand that most prevention is not about healthcare. So I'm going to look at this a little today and look at how real the prevention problem is, and particularly in relation to cardiovascular disease, what the NHS role is in prevention, and why it's a big issue for primary care. And I'm also going to consider how at this time of major change that we're going through is actually a real opportunity to get better at prevention and at the same time reduce demand on our time. So a principal reason that we're interested in prevention, of course, is that most premature deaths are avoidable. So there are about 150,000 deaths in England each year under the age of 75. And it's estimated that around 2/3 of these are avoidable through prevention or through treatment. Now, the Global Burden of Disease study in 2013 examined what it is that causes premature death, disability in our patients, in our communities. The different colours in the chart, a big challenge for me as I'm colourblind, but the various colours relate to different diseases like cardiovascular disease, cancer, respiratory disease, etc. And the list in the vertical axis, these are the big risk factors in order of magnitude. So as we'd expect, behavioural risk factors such as diet, tobacco, alcohol, physical activity, those are big hitters, big determinants of whether people are disabled or die prematurely. But also in there are the clinical risk factors like raised blood pressure, raised blood sugar, raised cholesterol, chronic kidney disease. And drawing from that data, that we can see that cardiovascular disease is second only to cancer as the leading cause of death and disability in our patients. Now, all of us will be aware that CVD has actually been the success story of the last 30 years with a dramatic fall in mortality. But there hasn't been as a parallel change in the disease burden associated with that. So we've seen little change in prevalence over the years for cardiovascular disease in men and women at various ages. And of course, in primary care, we've seen a dramatic rise in expenditure. So this is the burden of cardiovascular disease rising in primary care that has helped to bring about that substantial fall in mortality. And other things are going to mean that this burden gets only bigger. The population is very much getting older, and you can see just in this 12-year period from 2010 that there's going to be a 44% increase in people over the age of 85 in England. Of course, bringing with them more long-term conditions, more preventable illness, more reliance on healthcare. And of course, obesity is a major epidemic, and this is driving much of the preventable illness in the UK as elsewhere. We now have 2/3 of adults who are overweight or obese. 1/3 of our children going into secondary school are overweight or obese, and 1 in 5 children going to primary school are arriving with that major threat for their future health. And of course, obesity, big driver of premature mortality, but particularly through type 2 diabetes. Diabetes that currently costs 10% of the NHS budget, and with the predicted growth in diabetes matching the predicted growth in obesity, this does threaten to break the NHS bank in the not too distant future. So in cardiovascular disease, we have a substantial disease burden and a growing disease burden. It's responsible for about 1 in 4 premature deaths. It costs a fortune. £7 billion of the NHS money goes on it every year, and large amounts also on social care. And there's also a big health inequalities element. So in the practice I work in, very deprived part of Runcorn, my patients are twice as likely to die prematurely from cardiovascular disease than people who live in more affluent areas, like where I live, for example, in Shrewsbury. So this is the rationale behind one of these phrases that appeared in the 5-year forward view, that we actually need to get serious. We need a radical upgrade in prevention if the NHS is to be sustainable, really in very much in the short-term future. But as health professionals, in the NHS, we all know the main causes of preventable illness are not something we can influence as doctors and nurses. Things like the diet people eat, people's reluctance to take exercise no matter how attractive you make the staircase, the sedentary lifestyle that all of us are living these days with a lot of time spent in front of screens. I think it's a really legitimate question. What can the NHS do about any of this? Well, I think the answer is twofold. The answer is yes, absolutely, that is right. Population level measures have the greatest impact and we must pursue them with vigour. But the NHS has a critical and actually a substantial contribution to make in prevention, and that's what I'm going to explore a bit further. So in looking at prevention, in terms of the NHS, I think it's worth considering these three areas. So population level interventions, behaviour change support, and early diagnosis and treatment of high-risk conditions. So if we look first at population measures, what is it that the NHS can do in this arena? Well, clearly, national action such as tobacco control, changes to food formulation, the obesity strategy, these are all going to be contributors. We know, for example, that the fall in recent years, the reduction in salt in foods that we're buying has been matched by a significant reduction in population blood pressure. There's also a lot of scope for local population level interventions to prevent illness in the future and make the NHS sustainable. And the STPs that Maureen has discussed are very much taking a place-based approach to establishing what we need, what services we need, but also how can we prevent illness. Partnerships that include the NHS and local authority, but also wider businesses and schools, etc. And in terms of prevention, there are a lot of levers that are available, and some of them are used. So the planning and licensing and regulations, approaches to marketing, mass catering, etc., and healthy workplace, healthy schools. Lots of approaches like that. So, for example, we know clearly that streets that promote social interaction and exercise are streets that are difficult to drive down, but they're easy to walk and cycle along. And that's something that's very much in the domain of local authorities to address. But so too is the environment that our children are exposed to on the way to school. And this is a cutting from the Daily Mirror, nicknamed Chubby Mile. The road with 34 takeaways, fast food takeaways on the way to children's school. And then there are really positive examples. So the wonderful example from Scotland, where the head teacher has the children running every day to bring physical activity into their routine, is likely to have a significant impact on those children's health. And that's been very enthusiastically taken up by schools all across the United Kingdom. In many places, there's partnership between local authorities and businesses to work up active travel plans to reduce the impact of sedentary work. And this is an example of a local authority partnership with food outlets throughout Cambridgeshire, with resources and tips and support to help the food outlets provide healthier options for people going in to eat, rather than having chocolate added to their meal deal, for example. So what's that got to do with us? Well, the STPs are meant to have responsibility for shaping services, as Maureen said, and they're meant to have responsibility for promoting population health. I think this is a real opportunity for us in primary care, not to be defensive about prevention, but actually to be quite assertive about prevention. Ask challenging questions of local authorities and others. What are you doing to support healthier lifestyles amongst our patients and keep our patients away from our surgery? An opportunity for us to be advocates for a system-wide approach to health and well-being that complements what we're doing in the NHS. And so for our GP leaders and nurse leaders in the CCGs, working with the STPs, I think this is an opportunity to provide system leadership, to support the STPs, actually to champion a population health approach. So I'd like to move on now to behaviour change. And interestingly, when we talk about prevention in NHS, people tend to think about support for behaviour change, and that's often how it gets characterised. And sure, there's lots of opportunities for us to do this. So 1 million daily consultations across the whole of primary care, lots of opportunities to identify risk factors and advise and provide brief interventions and signposting. And of course, we all do that in our day job. But the reality is it's not always easy. And we all have many other priorities in what are very complex consultations in general practice, and we often lack the time to do prevention. Now, I know there are issues to debate around the NHS Health Check, but as a national programme, it is now in place. 1.5 million people every year are having an NHS Health Check. The diabetes prevention programme has been launched and is now rolling out. Will cover every health economy over the next year or so. And I think this is bringing us some support in primary care, bringing a systematic approach to risk factor detection and management. But it's a big issue for us. With limited capacity, how can we do better at primary prevention and primary care? Well, there are a lot of new models of primary prevention emerging, some of which Arvind referred to. So social prescribing, well-being hubs that are springing up in a lot of areas, linked to practices, staff engaging with patients in the waiting rooms, taking referral from us and supporting access to services for overweight or diet or physical activity, etc. But also taking referrals for stress and loneliness and family problems, the things that often stop people taking on and getting active about their own health, and often mean that they come and visit us more often. The social prescribing and wellbeing hubs are often taking up this sort of work. So these are models that bring new skills and resources to bear in prevention in primary care. And they're models that can divert work away from us in general practice. And I think this does build on the concept of general practice as a gateway. So perhaps seen as less as providers of prevention, we're going to do some, but more as a gateway into prevention resources in the community. And some examples. So where I work in Runcorn, the Halton Wellbeing Enterprises runs a fantastic programme. Healthworks Newcastle, many of you may have heard of that. It's been around quite a few years and well established and integrated with primary care locally. Wellbeing Salford in Greater Manchester. So I think it is an opportunity for us to get creative about prevention. And what's key about these new models of prevention is that they're making the system work better for us and our patients, getting patients better access to preventive resources while reducing the demand on us as GPs and others in primary care. So finally, I'd like to move on to secondary prevention. And this is our day job, isn't it? This is very much core general practice. So in relation to cardiovascular disease, blood pressure, AF, cholesterol, diabetes, non-diabetic hyperglycemia, and CKD, these are all conditions where we know there's a very strong evidence base of an increased risk of heart attack and stroke. So what is the evidence around increased risk? And I'm just going to take 3 examples. So high blood pressure, we know that it contributes to half of all strokes and heart attacks in our patients. Atrial fibrillation, if you've got AF, you're 5 times more likely to have a stroke. And if you have a stroke with AF, you're much more likely to die from it and to be severely disabled. And with cholesterol, we know rising cholesterol, progressive increase in the risk of strokes and heart attacks. What about the evidence of the benefit of treatment for these conditions? So if we look again at blood pressure, excellent, very robust meta-analysis data that shows for every 10 millimeters mercury drop in systolic blood pressure reduces the risk of cardiovascular events by 20%, probably down to 130 over 130 systolic, potentially lower than that. With atrial fibrillation, 5-fold risk of stroke, but if we anticoagulate the patient, that stroke risk drops by 2/3. How many treatments in general practice do we have that has that sort of return on investment? And for high cholesterol, the excellent, very robust study published 2 or 3 weeks ago in the Lancet, every 1 millimole per litre drop in cholesterol reduces the risk of a cardiovascular event for an individual by 1/4 every year. So really substantial health gains. So This slide doesn't look as it was meant to, and it worries me that my slides aren't going to be quite right from here, so may not have the right version, but bear with me. But the key question at the top there is, what about overdiagnosis and overtreatment? Because I think that is a very critical question. Because we know, in general practice at the front line, we can cause harm to our patients by slavishly following guidelines. And more treatment brings more risks, especially to people with multimorbidity, people with frailty. So if we're using guidelines around blood pressure or AF, and we want to optimize the care for our patients, it's really important we consider the risks and the benefits for that individual and to assess what's the treatment burden for this person in front of me. So as the new NICE guidance on multimorbidity articulates, our aim should be to personalize care, balancing the guidelines with the best interests of the patients. So yeah, absolutely, I think that's a key consideration for us in our day job. But an equally important consideration is the risk of underdiagnosis and undertreatment of the patient in front of us. And patients may also be harmed if we don't identify their high risk of cardiovascular disease and offer them treatments that might prevent a heart attack or stroke. But again, this is our day job, managing this complexity, these challenging situations, balancing the risks of over and underdiagnosis, balancing the risks of over and undertreatment. It's one of our key roles as GPs and nurses, and certainly one of our core challenges. So if we just go back again to look at what's the opportunity here for improvement in England in managing these high-risk conditions, how well are we doing currently? So if we take high blood pressure, currently we're picking up about 60% of people with hypertension. And when we pick them up and they go on our QOF register, we're treating about 60% of them to the 140/90 target. I find that so striking. When I was at medical school 30-odd years ago, I was taught the rule of halves, and we haven't progressed a great deal in that time, despite having one of the best general practice systems in the world. With atrial fibrillation, although we know how effective anticoagulation is for our patients, if you take the people on my register, they've got AF, it's recorded, when they go into hospital and have their stroke, only 1/3 of those people will have been anticoagulated, despite the benefits that the treatment can offer. And with high cholesterol, there's debate about what level you should offer statins, of course, and of course, behavior change is the most important thing to focus on here. But only probably less than half of people who've got a 10-year CVD risk above 20%, less than half are getting statins. So clearly a lot of potential to improve outcomes for our patients by improving secondary prevention. And NICE's model, for example, if we take atrial fibrillation again, if everybody who was eligible for anticoagulants in AF got their anticoagulants, there'd be 10,000 fewer strokes a year. That's a very large number. And clearly not all of those people would be appropriate, but I suspect a majority would. But even if we only reached 50% of those people, we'd still be saving 5,000 strokes a year. That's 25 strokes in every CCG, so not an inconsiderable gain for our patients. But that's all very well. And it's really important, as we all do in this room, to think about the real world that we live in general practice. We're all very much overworked, and we have zero capacity to be doing extra stuff. So pulse taking, blood pressure checking, counselling about statins might sound very easy, and we know it's important, but it's often trumped by other priorities that the patients bring to us. Patients often have multiple priorities of their own that they bring to consultations that don't leave time to talk about anything else. So I don't think we're going to improve care and outcomes by working harder. That's clearly not an option for any of us. I think it's only going to be achieved by doing things quite differently. In other words, by making the system work better for us and for our patients. Now, this is graph. This shows a variation across the country in stroke prevention in atrial fibrillation. So I told you that about 1 in 3 patients who have a stroke will have been anticoagulated. This shows the variation across CCGs across the country. It's actually from about 20% up to 70%. So clearly, some places, some practices, some CCGs are managing to do different things in order to get higher treatment rates. And practices and colleagues around the country are all taking this on board, this approach to doing things differently. So this is a practice in Stowe who installed one of these big blood pressure machines in their waiting room that's validated. Patient gets their call up to have their blood pressure checked on the hypertension register. They come in and measure it themselves. They go to the receptionist. The reception works to protocol. Yes, your blood pressure's within the parameters set by the GP. We'll call you again in 6 months. Or, no, your blood pressure's a bit high. I'll get you to see the nurse. And people who are not known to be hypertensive will be picked up and then offered a consultation. Now, in this practice, they found they picked up significantly more new hypertensives. They significantly improved the number of people with optimal treatment, and they released a large amount of clinician time every month, being creative, doing things differently. In Dudley, they've used the practice pharmacist scheme that Arvind told us about, using this new funding to manage hypertension. So taking a lot of work off the GPs, finding more hypertensives, optimizing their treatment, and they've had significant results. In Stoke, they've been using telehealth quite a lot. In this example, using telehealth to input blood pressure readings to the practice so that treatment can be optimized remotely or with limited contact. And in Bradford, they're doing things at amazing industrial scale. In Bradford, all the GPs are working together, all the practices, they share data, they access their data and identify people who are not adequately controlled on warfarin or blood pressure or not on the right statins. And they've taken a system-wide approach across the CCG to finding and managing those people. So they're getting much better outcomes and they're reducing the workload for practices. And that's, I think, is really creative and has to be the way forward. Now, Chris Harris, who's led this work in Bradford, is talking about this program tomorrow afternoon. It's well worth listening to. So how are we, drawing on those examples, how are we going to make the system work better to improve detection and management of these high-risk conditions in particular? So the RCGP, as many of you will know, is developing a whole range of resources about quality improvement, and quality improvement is going to be much more important for the college in the years to come. They're developing specific resources for practices to help us improve what we do at practice level. Last week, Joanna Bircher and colleagues published the diabetes QI resource, which is now available online. So really helpful at practice level to help us get better ourselves. But I think a lot is going to come from this atmosphere, this environment we're now in, of a redesign of general practice to help us improve outcomes for our patients, but also reduce a demand on GPs. And this is going to be through new ways of doing things in the surgery, new models of care using community pharmacists, for example. So for the diagnosis, not just blood pressure measurement and sending the patient to see us because their blood pressure is 142 and they're afraid they're going to have a stroke, but measuring the blood pressure and arranging ambulatory monitoring and arranging the blood tests and sending the person to us with a diagnosis. Anticoagulant monitoring, supporting adherence for people on statins and anticoagulants where we know that's an issue. Accelerating access to new technologies and use of self-monitoring and telehealth solutions, for example. Last week also, NHS Right Care published the CVD prevention pathway, worth looking at online. This is going to bring systematic approach to CCGs across the country. This is a systematic approach to improve the detection and management of these high-risk CVD conditions, and to do it in a way that is novel, that doesn't impose new work on general practice. And that's what's in the pathway. So I think that will be very helpful to us all. So energising general practice is the theme of the conference, energising primary care. And I think there's a real opportunity for us here in prevention to increase what we do in prevention in primary care, but at the same time reduce demand and improve outcomes for our patients. I think our starting point has got to be, and this is why we have to get serious about prevention, to recognise this is an existential threat that we face in the NHS. If we don't get serious about prevention over the next 5 years or so, we have a real problem in sustainability in the health service. But second of all, we've got to acknowledge and make sure everyone else acknowledges our lack of capacity to do more. But we should grab the opportunity that comes from the 5-year forward view and the GP forward view, rather, the new models of care, STPs, and all this other stuff that's going on. Firstly, to raise our voice in system leadership in the STPs around population health, asking local authorities, what are you doing to support people to keep healthy? Building these partnerships with local authorities and communities to expand social prescribing, for example, under wellbeing hubs on primary prevention. So again, something that's going to benefit patients and reduce our workload. But also to build these new models of care to improve detection and secondary prevention in these high-risk conditions. And I think it's really worth us focusing on number 3 as a priority, because if we get better at secondary prevention in the way that is possible, this is clearly going to improve outcomes for our patients. We'll be stopping a lot of heart attacks and strokes, and in a relatively short time frame. So a major return on investment in that. So finally, I think as a profession, we should consciously rise to the prevention challenge. I know we get defensive about it, and our magazines help us to be defensive about prevention. I think we need to rise to the challenge and challenge ourselves as GPs and nurses and others, and challenge ourselves as a college to lead the conversation about prevention in the NHS. Not to be following it, but make sure that the solutions that are developed around prevention very much reflect our real world in general practice. And I'll be really looking forward to working with the college and our new chair over the coming months to help build that leadership in this important area. I think secondly, to rise to the challenge of challenging our partners to do more to help our patients to stay healthy, and to challenge the primary care system to find more effective ways of identifying and treating these high-risk conditions, because it will reduce the burden of heart attacks, strokes, and premature death and disability in our patients, and it will help to reduce our burden. So I think I've gone slightly over time. Apologies for that. Thank you very much for listening.